Hello, Dr. Aizaz from MedicoVisual.com back with another visual lecture on the topic of pathogenesis of coronavirus from Coronavirus Visual Lecture Series. In this visual lecture, we will talk about the pathogenesis of coronavirus, that how coronavirus causes the disease and how it can kill a person, right? So, as I've told you in the previous lecture, that with each replicative cycle, thousands of particles of coronaviruses they are released into the alveolar sacs or air sacs of the patient, right? So what will happen there? These large number of coronavirus particles they can initiate a strong immune response, right? So what will happen that they will trigger immune response, because here you know that macrophages are present in the alveoli. Macrophages are present, and these macrophages they will engulf these virus particles. And as they engulf these virus particles, they will present their spike proteins and other viral proteins. Macrophages will present the viral proteins on their special antigen presenting receptors called MHC type 2 receptor. So they will present these viral proteins on MHC type 2 receptors. And of course, you know that these viral proteins, spike proteins, these are also expressed on type 2 alveolar pneumocytes. When the virus infects these cells, these spike receptors, spike proteins, these are also expressed on these receptors. Now what will happen that these macrophages, as they engulf these viruses and present their receptors, their proteins on them, they will also call for help, right? They will say that they have caught something dangerous, they have caught an enemy, so they will call for help. They will release some special chemical messengers called interleukins and other cytokines. So they will release interleukins and cytokines, and with the release of these interleukins and cytokines, they will recruit other white blood cells at the site of this infection, right? They will call other white blood cells. Especially in the case of viruses, they love to call cytotoxic T cells, right? So in blood vessel, here let's suppose they release into bloodstream these interleukins, and this cytotoxic cell, he was wandering into this bloodstream, and of course this will be recruited on the message of these interleukins, right? And when this cytotoxic T cell, when it will encounter these spike proteins that are presented on type 2 pneumocyte, what it will do? It will think that this cell is something dangerous, because this cell is presenting some foreign protein which is not the body protein, right? Which is not the part of body. It is presenting some foreign protein. So this cytotoxic T cell will consider this type 2 pneumocyte as a foreign cell, right? It will consider it enemy, and it will do something very weird. It will do something horrible with this. It will kill its own cell, right? It will kill this cytotoxic T cell. And how it is gonna kill this cytotoxic T cell? It is going to release some special chemical grenades. What are those chemical grenades? These are called granzymes. So it will release these granzymes, and these granzymes will perforate the membrane of the granzymes and perforins, which will destroy this this type 2 pneumocyte. It will perforate the membrane of this, and the cell will be destroyed. Or it can also initiate apoptosis pathway in this cell, right? So this cell will be destroyed. So what happened that this virus, as it triggered the inflammation, so there is lots of inflammation going on, and what will happen? And of course interleukins and chemokines are also there, and of course you know here is the hypothalamus along with pituitary, right? So in hypothalamus there is special thermoregulatory center. In hypothalamus there is thermoregulatory center which is concerned with regulation of body temperature. Normally our body temperature is is set point is normally around 37 degrees C, right? Thermostat is set around 37 degrees C. What these interleukins and other cytokines will do is that they will affect this this thermoregulatory center, and it will alter this thermostat. It will increase the thermostat. It will increase it to from, let's say, 37 to 38. So what will happen? There will be fever. Along with that, of course, because inflammatory response is going on in this alveoli, in the site of gaseous exchange, inflammation is going on. So what will happen? That the patient will try to cough up, right? A patient will try to clear up these inflammatory cells and viruses. So due to irritation, patient will try to cough up. So, but here you can see there is minimum fluid present. There is not much fluid present at this stage, right? So because of this, there will be cough, but cough will be dry, non-productive cough. Sputum will not be there, right? And shortness of breath can be there because due to inflammation, and if this inflammation involves multiple alveoli, right? What will happen if it involves multiple alveoli? The function of alveoli will be disturbed. Of course, function of alveoli is to exchange the gases, right? So exchange of gases will be suffer. Exchange of gases will suffer, so there will be shortness of breath. So all these are symptoms of atypical pneumonia. And atypical pneumonia, if it is due to SARS coronavirus 2, SARS-CoV-2, it is called COVID-19. And if atypical pneumonia is due to SARS coronavirus, not SARS-2, it is due to SARS, then it is called SARS. SARS means severe acute respiratory syndrome, right? Another thing about the difference between COVID-19 and SARS is that right now, from preliminary data, right now what we have seen is that the fatality rate of COVID-19 is about 3%, right? COVID-19 fatality rate is 3%, meaning that it is fatal in about 3% of cases, right? And fatality rate of SARS is about near about 9 to 10%, right? So up till now, what we know is that COVID-19 is fortunately less fatal as per these preliminary report, right? We may get more precise data later on, but right now we know that it is a bit less fatal than SARS. Okay, so let's move forward. This was the pathogenesis and clinical features of atypical pneumonia. Now we will discuss the common complication of this disease, that is ARDS, right? So here I want to highlight another thing. Here I want to rather ask you a question, that why there is dry cough in this atypical pneumonia, in this coronaviral infection, why there is dry cough in coronaviral infection, and why there is productive cough in typical pneumonia, in typical bacterial pneumonia. Of course, reason I have told you that there is less sputum in case of coronavirus infection or atypical pneumonia. But why it is so? Why there is less sputum? Well, first we have seen the viral thing. Now we will talk about bacterial here briefly. That in case of bacterial infection, let's suppose this is a bacteria. In case of bacterial infection, macrophages will mainly call for help, and it will mainly call not cytotoxic T cell, but it will mainly call what? Neutrophils. Neutrophils are professionally developed in such a way that they are specialized in killing bacteria, right? So they will try to kill bacteria. Now as neutrophil try to kill bacteria, bacteria have equipped themselves with the capability to fight back, right? Bacteria will release certain exotoxins which will lead to killing of some neutrophils as well, right? So neutrophils will die in such case, right? So, and of course some neutrophils and other white blood cells, they may overpower this bacteria and they will be successful in killing these bacteria as well, right? So in this situation, inflammation is much more marked, right? It is much more pronounced in case of bacterial infection, because bacteria can fight back with these white blood cells. So more white blood cell will be recruited at the site and full-fledged war is going on here, right? It is a zone of full-fledged war. So there is full fight going on between bacteria and neutrophil. So what will happen that due to increased inflammation, there will be increased leakiness of these vessels and fluid will be pulled into these alveoli, right? And this fluid, it will contain what? It will contain dead and living neutrophils and other white blood cells. Along with that, there will be dead and living bacteria and dead necrotic epithelial tissues will be there in this fluid. Now this fluid, all this fluid is actually that forms sputum. So when such patient of bacterial pneumonia, when he or she coughs, this sputum will come along, right? And we call it productive cough. Now compare it with viral pneumonia. In atypical pneumonia, cytotoxic T cell, our body's own soldier, they are killing body's own cell. So will these body's own cell, will these non-suspecting cell, will they be able to fight back with their own soldiers? Of course no. They are being killed by their own people. Oh, life is unfortunate sometimes. Your own people sometimes turn against you at the times of extreme misery. And that's what hurts the most, right? So let's talk further about the pathogenesis of this disease, right? So what will happen next? Of course, this is bacterial and this is viral, and now you know why there is difference. Now another thing, why epithelial cell die? So type 2 epithelial cells, these are mainly murdered by cytotoxic T cell. And of course, when inflammation is going on here, not only type 2 pneumocytes will die, type 1 pneumocyte will also die in this pro-inflammatory environment. So immune mediated damage is the one cause. Other causes, apoptosis or apoptosis, whatever you like to call. Now some of these type 2 pneumocytes, they may undergo programmed cell death. Why? Because their protein synthesis suffers, right? Why? Because these cells, they have shifted their focus towards synthesis of creating viral proteins, right? So they won't be able to create their own essential proteins in sufficient amount. They won't be able to create those proteins that are required for the cell to survive. So they can't survive in such circumstances. Along with that, as I told you in previous lecture, that DMVs, double membrane vesicles, are being formed from endoplasmic reticulum. So endoplasmic reticulum will bud and form lots of DMVs. And when these virus particles, thousands of viral particles are being released from endoplasmic reticulum, they will go to Golgi apparatus. So again here, endoplasmic reticulum will be divided into these vesicles. So all this will lead to endoplasmic reticular stress, which is a factor to cause apoptosis, right? And also it is believed that some non-structural proteins of coronavirus itself can induce apoptosis. The exact mechanism is not known, but all we know is that it can cause apoptosis, right? So apoptosis can be immune mediated as well as, no, not apoptosis, epithelial cell killing can be immune mediated as well as by apoptosis. So what will happen next? Here I would like to highlight another aspect of pathogenesis of this disease. Okay, here is kidney, and from kidney, when the peripheral blood pressure, when systemic blood pressure is low, kidney will release a special enzyme or special protein called renin from its JG cell. It will release renin, And what this renin will do is that there is a plasma protein called angiotensin. Angiotensinogen, not angiotensin, angiotensinogen. It is an inactive substance. It is an inactive plasma protein which is normally present in plasma. Renin will act on this angiotensinogen and it will convert this angiotensinogen into angiotensin 1, right? So this angiotensin 1, it will go to the lung capillaries, and in lung capillaries endothelial cells there are some special transmembrane enzymes or receptors. There are transmembrane enzymes called ACE enzymes, right? ACE mean angiotensin converting enzymes. So these ACE enzymes, these transmembrane enzymes, they will act on angiotensin 1 and they will convert angiotensin 1 into its active form called angiotensin 2. Now, angiotensin 2 is potent vasoconstrictor. It has a number of functions. I am not going to discuss all these, but what it does that it increase in locally, if we talk about its effect on lungs, local effect is that it will increase hydrostatic pressure. Of course, you know, it is a vasoconstrictor and it increase blood pressure systemically. So it will also increase blood pressure in lung vessels, right? So when lung vascular pressure is increased, it will cause increase in hydrostatic pressure. It will increase pressure that is in these vessels. So along with that, it has another role that it will increase lung vascular permeability. It increases lung vascular permeability. And another thing, it will activate immune cells. Now you see the problem here. At one end, the presence of coronavirus particles, they have activated immune cells with the mechanism of macrophages, you know. They have activated immune cells. Now angiotensin 2, it can further activate immune cells. It can further enhance the immunogenic response, right? So immune response will be exaggerated when angiotensin 2 is present. But normally what happens that this angiotensin 2, it is inactivated by angiotensin converting enzyme type 2, by ACE2. ACE2 receptors are present here. ACE2 is also enzyme, and ACE2 acts in opposite manner of ACE1. So ACE1 generate angiotensin 2 and ACE2 inactivate it, right? So angiotensin 2 will be converted into angiotensin 1 to 7, right? It will be converted into angiotensin 1 to 7, which is its inactive form of, and it will be done by ACE2 receptor. Now you see the problem that what happens in coronavirus infections, that type 2 pneumocytes machinery, protein synthesizing machinery is hijacked. Now this type 2 pneumocyte, it won't be synthesizing its own protein. It will mainly synthesize viral proteins, right? So will it be able to sufficiently synthesize angiotensin converting enzyme type 2 receptors? Of course no. So ACE2 receptors will be down regulated. What they say is that due to coronavirus infection, ACE2 receptors are down regulated. So these cells will present less ACE2 receptor. So what will happen? First of all, as I told you from this discussion, you know, ACE1 receptors are pro-inflammatory. Why pro-inflammatory? Because they generate what? Angiotensin 2, and which will cause increased vascular leakiness, and they will recruit more immune cells. They will activate more immune cells. So it is pro-inflammatory. While because ACE2, it inactivates angiotensin 2, so it is anti-inflammatory. And what happens in case of coronavirus infection, that these ACE2 are down regulated. So ACE2 is decreased. So these ACE1, they will be overpowered. So what will happen? These pro-inflammatory ACE1, when they are overpowered, inflammation is further exaggerated, right? Inflammation is further exaggerated. Now what will happen? When there will be further exaggeration of immune response, more and more epithelial cell will start to die. What we call is that there will be diffuse alveolar damage. There will be diffuse alveolar damage, right? So what will happen due to diffuse alveolar damage? And another thing I am gonna tell you here, that these type 2 pneumocyte, what they do, another thing they do is that they make a special substance called surfactant. They create this chemical called surfactant, and surfactant, it encircles, it lies these alveoli. And surfactant, what surfactant does is that it decreases the surface tension of alveoli, and by decreasing surface tension of alveoli, it makes alveoli more compliant, it makes alveoli more elastic, it makes alveoli easy to expand, right? So with small pressure, with small amount of air pressure, alveoli easily expands in the presence of surfactant. And when surfactant become dysfunctional, right, when surfactant become dysfunctional, will these alveoli be able to easily expand? No. So their expansion will suffer. They become less compliant, and when they become less compliant, they tend to collapse. Now another thing, now alveoli will tend to collapse. Along with that, these vessels, they have become more leaky. Their hydrostatic pressure has increased. So what will happen? Due to its potential to collapse, as they are collapsing, this will generate a negative suction pressure will be created. So because of presence of this negative suction pressure, as they are trying to collapse, and it will pull, the suction pressure will pull fluid from these leaky vessels, right? It will pull fluid from these leaky vessels, and in those leaky vessel, pressure is already there. So all these things, this will lead to what? This will lead to alveoli, some of the alveoli which are collapsed, and then there are some alveoli which are collapsed. Along with that, they are filled with fluid. So such alveoli, in the presence of such alveoli, and if such alveoli become large in number, will the patient be able to breathe? No, he or she will not be able to breathe properly. So he or she will have severe respiratory distress, right? And with the presence of severe respiratory distress, that would be an emergency. He or she might need ventilatory support, right? So surfactant dysfunction. So surfactant dysfunction plus pro-inflammatory environment, this will lead to what? Collapsed lungs, collapsed alveoli plus fluid-filled alveoli, and patient won't be able to breathe, and that's what we call it, respiratory distress, acute respiratory distress syndrome, and it is also called respiratory failure. It is a type of respiratory failure, right? And it is caused due to diffuse alveolar damage. So all these are the names of same thing: acute lung injury, diffuse alveolar damage, and ARDS. Diffuse alveolar damage is pathogenic term, right? So what will be the clinical features? That there will be severe respiratory difficulty in breathing. Partial pressure of oxygen will be decreased because gaseous exchange suffers, so partial pressure of oxygen will be decreased. And then cyanosis, of course cyanosis may develop, and patient would need ventilatory support. It's an emergency, otherwise patient might die. So this ARDS is the major complication of SARS and COVID-19, and this is the thing which can kill the patient, right? And here another thing, if patient of course, in such case, in atypical pneumonia, as I told you, that there will be dry cough. But now when these alveoli, they are collapsed and they are filled with fluid, now the cough would be productive. But productive cough is not the major problem here. The main thing is that there will be very severe respiratory difficulty. Patient won't be able to breathe, right? So this is the ARDS, which is a major complication of COVID-19 and SARS. Another thing I would talk about viremia, that sometimes what happens that due from these leaky vessels and these inflammatory environments, some of the virus particles, coronavirus particle, they may leak, they may spill over into bloodstream, and they may reach to other organs as well. So there may be some other complications of this disease. I am not gonna go into details, that it's beyond the scope of this lecture. So this was about the pathogenesis of coronavirus. Let's quickly review, right? Should we review it? Okay, so what happens in coronavirus? So first of all, of course, there are a lot of virus particles. Virus particles will do what? They will be presented by macrophage, they will be eaten up, presented by macrophage, and macrophages will call for help. They will recruit cytotoxic T cells. Cytotoxic T cell, they will kill alveolar pneumocyte, type 2 alveolar pneumocyte, and due to killing of type 2 alveolar pneumocytes and inflammation going on there, it will lead to what? It will lead to symptoms such as dry cough, fever, and malaise. And fever will also mainly be due to cytokines that are released, and that will affect the thermostat. So all these things, and of course there will be difficulty in breathing, right? Shortness of breath. All these are the symptom of COVID-19 or SARS, which are the atypical pneumonia, right? And of course the complication is ARDS, and how ARDS develop, that when inflammation becomes marked due to down regulation of ACE2 receptor, the pro-inflammatory environment is created. So in this pro-inflammatory environment, inflammation becomes much more marked, and along with that there is surfactant deficiency, and surfactant deficiency will lead to collapse of alveoli. So collapse of alveoli due to surfactant deficiency, and increased leakiness of capillaries due to ACE2 down regulation. It will lead to what? Acute Respiratory Distress Syndrome. So this was about the pathogenesis of coronavirus. In next lecture, we will talk about that how we will diagnose this disease, COVID-19 and SARS. Mainly I will talk about COVID-19, that how we will diagnose it, what are the investigations that are to be done, and clinical features I have already discussed in this lecture. Then I will also talk about briefly about some aspects of its treatment. Thank you for watching this lecture. If you like this video, please subscribe to my channel. Please also give your precious comments about this video, right? See you in next lecture.